a very important session on the impact of urbanization on public health in India, and I'm sure this is an opportunity for most of us to draw lessons. We have 6 presentation series of presentations and 2 presenters with a very rich experience. We have organized the presentation in such a way that the first 2 presentations will be chaired by myself, and then we will be having the next two set of presentations by my colleague Muti, and then the final 2 presentations again will then be addressed after having some interactions on those presentations. So without further ado, I would like to introduce the first presenter, Dr. Vani Sethi, who is a PhD in public health nutrition and has 10 years of experience in programming, research and policy advocacy. She is a research and a program specialist on urban health. The floor is yours, Vani.
Off, please.
Yeah.
Okay, thank you very much. Thank you very much. I'll be taking the first 2 presentations, and these first 2 presentations deals with the household food insecurity problem and the problem of chronic undernutrition among the urban poor in India. All right? The first presentation. We tried to adapt and validate an experience-based measure of household food insecurity in urban slums of North India, and I'll be sharing with you some of our experiences on that. India is a population of 1.2 billion. 1/3 of India is urban, and 1/4 of urban India lives in poverty conditions in slums and informal settlements. In terms of numbers, there are 97 million urban poor in India. India's urban poor struggle to secure basic essentials. Every second child in urban poor settings is chronically undernourished. Every third mother is acutely undernourished. Household food insecurity is an important determinant of chronic undernutrition. And while we have large-scale surveys being done on periodic basis, we have nutrition surveys that are done using dietary methods, weighment methods. We do not have large-scale data on household food insecurity experiences of families and incorporating these questions in large-scale surveys, unlike the United States. We all know that United States Department of Agriculture has developed household food insecurity access scales, which have 18 questions, and then they have 6 questions which you can incorporate in large-scale surveys and find out what are the household food insecurity experiences that families have. Given this background, that there was no large-scale, large sample size, city-level data on household food insecurity in urban slum context in India, while we were doing a maternal and child health DHS-like design survey in one of the medium-sized cities of India, we thought, why not incorporate those 6-odd questions into the survey and find out what is the household food insecurity experiences of that family. Also identify what are the household food insecurity predictors among the urban poor in India in a medium-sized city, that is about 1.4 million population. And also test that can a US scale be adapted to Indian context for cross-cultural use, and is it valid and reliable to be used? So, we conducted a household-based cross-sectional study. It was conducted between October 2007 and March 2008, using a demographic health survey-like study design, We identified 40,000 married reproductive aged women across 75 slums that were randomly selected. This city of India is a medium-sized city. As I have mentioned, it has a 1.4 million population, and the slum population in that city is 0.65 million. So you can see the urban poverty in that city. The 6-item short-form questionnaire that was developed by the United States Department of Agriculture was used by us after 2 adaptations, which I will take in the next slide. In order to assess the predictors of household food insecurity, we used binary logistic regression, and in order to test whether the scale is valid and reliable enough to be used further in large-scale surveys in Indian context, we used Cronbach alpha and rash-based item fit statistics. And for this, I wish to acknowledge that we took support of one of the very senior persons, Dr. Mark Nord in US Department of Agriculture, who has developed the scale himself. This was the scale that we used. We asked the mother, while conducting this large-scale survey, which had a number of other questions, we also asked the mother, in the last 12 months, due to the lack of money, did you or any adult family member experience the following? Did you experience a condition where you could not afford to eat a balanced meal? The food that you bought did not last for the purchased period. You had to cut a meal size, or you had to skip a meal. And if the mother mentioned any of these conditions, we also asked, how often did you experience it? Was it rarely, often, or sometimes? After asking these 3 questions, we also asked, was it ever that anyone in your family, any adult member in your family, had to sleep hungry in the night? So these were simple questions that were asked from a family. If the family mentioned, yes, we experience these often or sometimes, they were considered affirmatives, and experiencing at least 2 out of the 4 conditions meant that the household experienced household food insecurity at least once in the past year, and experiencing 3 or more conditions meant that the household experienced household food insecurity with hunger. This is what we got. It was shocking, because till then, no city-level survey on household food insecurity was done. You can see here that 84% of the families mentioned that yes, they did experience conditions sometimes or often when they could not afford to eat a balanced meal. And as many as 1/5 of the sample population mentioned that yes, they experienced conditions where they had to sleep hungry. Given this, 3/4 of the sample population at least experienced household food insecurity once in the past 12 months. Then we went to find out what were the predictors of household food insecurity, and this is what we found. 3 important predictors emerged, and the most important one was income. Those families that belonged to the bottom 2 wealth quintiles were 4 times likely to be food insecure as compared to the others. Similarly, those families that were in the bottom 2 wealth quintiles were 5 times more likely to experience food insecurity without hunger as compared to families that were in the top 2 wealth quintiles. Other predictors of household food insecurity was belonging to a lower social group and having at least 5 or more members in the family. Looking at the scale's internal validity and reliability, the scale was sufficiently reliable. You can see the Cronbach alpha, it was 0.725, sufficiently reliable. However, validity was a question because there were fewer items. You can see here, in order to assess the validity of a scale, as I had mentioned, you have to use in-fit and out-fit statistics. And statistics should be around 1 so that you can get to know that the scale is sufficiently valid. And for 2 items, that is, you could not eat a nutritious meal and sleeping hungry, we've got a little deviant statistics, meaning that there were families who over-reported to these questions. Yeah, I think. So and that's my final slide. So what do we understand from this? The first thing, household food insecurity was a problem in the sample population. belonging to this medium-sized city, at least 75% of the families experience some kind of household food insecurity. Not only this, household food insecurity was 4 times higher in those families that belonged to the bottom 2 wealth quintiles as compared to the top 2. What does this tell us? Linkage to poverty alleviation programs are as important as compared to just linking urban poor population to food subsidies and nutrition programs. If food insecurity has to be reduced in an urban population, then linkage to poverty alleviation schemes and employment is as important. Coming to the scale, as I had mentioned, it had a sufficient reliability, but the validity was of a question. What does this tell us? The first, if the scale was of 6 items, we understood it would be better to retain the 6 items, rather we suggest to expand it to 8 items. Because if you look at here, I'm just going back to the slide on the scales, these were the 6 items suggested by the United States Department of Agriculture, and we actually merged some of the items. We suggest don't merge it. Rather, the cut and the skip meal item, at least in developing countries, should be split. The second thing was that we asked in the last 12 months preceding the inquiry, which is too long a period for recall. It is suggested that you should ask only the last 30 days. And the last thing about the scale is that the scale suggests that in the last question, sleeping hungry, we just said yes or no. If in this question also we had asked that how often did you experience the condition, and like other conditions we had taken only if you experience the condition often or sometimes means that you've actually experienced the condition, we would have got a much lower level of population that told us that they were experiencing hunger. Like in this slide, if you see, we got 20% of the population mentioned that they experienced hunger situations. But if we would have added that follow-on frequency question, maybe this percentage would be lower. Because if we take this data probably and discuss it with many bureaucrats, they would say 20% of my population is hungry. How can that be possible? It could result in controversies. So the final conclusion for this scales is that when adapting these scales to developing country context, it's better to expand the scale to more items and add frequency questions so that you can avoid over-reporting of answers and testing its validity in various settings. Thank you very much.